we're going to start. Still there are many people who's outside, but I think we should start for the sake of time. I'm Borja Ibáñez from the National Center for Cardiovascular Research, STEMI, and Hospital Fundación Jiménez Díaz. And it's my pleasure to co-chair this session with Professor Héctor Bueno, also from the CENIC and also from Hospital 12 Octubre. And we thought that it was important to have a session presenting the new guidelines from the European Society of Cardiology, presented in last September in 2017. So we're going to present 3 of these guidelines, and we hope that you are going to enjoy this session. So I'm going to pass now on to Professor Héctor Bueno.
So one of the issues that we always claim in Spain, we're underrepresented in the ESC and the scientific activities, but actually now we can show that there's Spanish protagonism in the guidelines. We have the privilege to have 3 people who have been deeply involved in the development of guidelines. Actually, one is the chair of these guidelines, the STEMI guidelines, which is Borja. And then we will be discussing, and I'm not sure whether you will get into the content or the backstage, because there's been a lot of cooking in the development of guidelines. I'm not sure whether you will get into that or we will leave it for the discussion, because that's something which is very interesting also, because there's always discussion on how the guidelines are released, but now, I mean, very few people understand how difficult it is to get these agreements and these statements, which is a lot of work, I can tell you, and a lot of merging of different thinking, which is probably the most challenging part of the guidelines, I can tell you. I hope that we can discuss that. With that, we will move on to the first presentations, which will be presented by Borja on the STEMI guidelines.
Thank you very much, Héctor. So we are going to start this session with the ST elevation myocardial infarction guidelines. I don't have any conflicts of interest to declare. So as you are aware, during the past European Society of Cardiology meeting, it was presented the ST elevation myocardial infarction guidelines. The previous guidelines were published in the year 2012. So the European Society of Cardiology thought it was important to incorporate all the new evidence arising from different trials and also meta-analysis. So this is why in the year 2015 we were able to have this committee or this task force for the preparation of these guidelines. I had the privilege of chair this task force along with Professor Stefan James from Sweden. And as you can see, also Héctor Bueno was also another Spanish member of this task force. So we think it was extremely important, not just a great opportunity for us, but also important for our country to have 2 members in these guidelines, as in any other guidelines, as you will see next. So we had 19 persons within this task force, and they are regionally distributed from all across Europe, as you can see. And these guidelines are not just the product of 19 members of the task force reviewing the literature, but also you have a significant number of reviewers that they go through all their different recommendations and texting. And in fact, you can see that we had in the first round more than 1,200 comments to address. So this is really a tough task, but we think it's extremely important because in the end, this product is meant to be the most balanced and the most honest product that we can present to the scientific community and the clinical community. As you know, the recommendations are presented in different classes of recommendations, 1, 2, or 3. As you can see in the ST elevation myocardial infarction guidelines, almost 60% of the recommendations are a class 1 recommendation. So this is telling that we have a lot of evidence in the care of patients with ST elevation myocardial infarction guidelines. And also it's important to discuss a little bit the level of recommendation. So you have a class of recommendation, 1, 2, or 3, but then also it's important to provide where is this evidence coming from, and this is where the level of evidence is coming from. As you know, the level of evidence A is when the data or the recommendation is based on multiple randomized clinical trials or meta-analysis. Level of evidence B is when data is derived from a single randomized clinical trial or large non-randomized studies. And the most striking one, or the most controversial one, is the level of evidence C, which usually is the consensus of the experts. As I told you before, is not just the task force, but also the reviewers, and it's mainly based on small studies or retrospective studies or registries. So if you see to the left of the slide, you will see that almost 50% of the recommendations had a level of evidence C, which might give you the impression that there is not enough data to support the recommendations. But I would like to show you and just to present some of the evidence with level of evidence C, and I think you will agree that it's not possible or not probable that we will be able to move ahead from the level of evidence C. For example, anticoagulation during primary PCI is a level of evidence C. So I think nobody will argue that patients should be under anticoagulation for primary PCI, but there is not a single randomized clinical trial randomizing patients to anticoagulation yes or anticoagulation no during primary PCI. Also, implement oxygen therapy in patients with hypoxemia, also to carry defibrillators in the ambulances, and many others. So despite 50% of the recommendations are level of evidence C, many of them, as you can see, are clearly established as therapies for patients with ST elevation myocardial infarction. This is the classical graph for the patient, how patients present with ST elevation and what should be the path that they should follow. So we did this cartoon, but this is similar to what have been presented before in the 2012 guidelines. So as you can see, as you know, the patients having chest pain can have 3 different forms of presentation. The patient can go straight to the primary PCI center, the patient can go straight to a hospital without primary PCI capabilities, or the patient can get in contact with the emergency medical service, and then the emergency medical service is bringing the patient to the hospital. So it's also important to remark that within these guidelines, we wanted to make clear what means the first medical contact, because this was not clear before. So in previous guidelines, first medical contact was not clear, and it wasn't clear whether this was when the patient was calling the emergency medical service or when the patient was presenting into the hospital. So this is why in these guidelines we wanted to deliver simple messages, and first medical contact is clearly described. Is that time point in which the patient is either initially assessed by a physician or any other healthcare provider that is able to diagnose myocardial infarction and also to implement first therapies, for example, defibrillation. So therefore, when the patient is calling the emergency medical service, this is not per se first medical contact, but only when there is someone who can take the diagnosis and also the first therapies. Also, it's very important to decide when the clock should start in order to decide which reperfusion therapy to implement. In the previous guidelines, this moment was the first medical contact, and this was not clearly defined, as I have just mentioned. And in this STEMI guidelines, we made clear that that time point should be at the moment in which you diagnose a patient with ST elevation myocardial infarction. So as you know, there are 2 different reperfusion strategies. Primary PCI, which is the best therapy compared head-to-head with thrombolysis, which is the second one, but there are some cases in which primary PCI is not immediately available, and for how long the delay and performing a primary PCI is balancing the benefits over thrombolysis. So it's clearly presented in these guidelines, despite this is not based on any ad hoc clinical trial, that this time point should be 120 minutes. So when the patient is diagnosed with ST elevation myocardial infarction, the healthcare provider should calculate how long would it take for the patient to have the wire passing through the occluded artery, so reperfusion by PCI. If this time is equal or less than 120 minutes, the patient should be delivered to primary PCI, and if it is expected that this is longer than 120 minutes, the patient should undergo immediate fibrinolysis and then transfer to a primary PCI center. In these guidelines also we remove some ambiguous terms like door to balloon or door to door or any doors, because this make sense in the past, but not any longer, because today we don't know where is the door. The door can be the door of the hospital, the door of the ambulance, or different doors. And in fact, we are recommending bypassing emergency medical services and so on. So this is why we think, or we thought, that the term door to balloon should be completely eliminated from the guidelines, and this is why you will see no doors in the 2017 clinical guidelines. So as I just mentioned, the strategy selection, primary PCI or thrombolysis is based on the uncalculated time from STEMI diagnosis to reperfusion. And it's very important to differentiate this time for strategy selection from the quality indicators. So it was also not clear in the previous guidelines and in different local procedures whether the patients presenting in a primary PCI center, the decision to undergo PCI or thrombolysis was based on these 60 minutes or 90 minutes in the case that patient was presenting out of the hospital. But it's extremely important to remark that these timings, a 90-minute objective when the patient is presenting outside of the primary PCI and 60 minutes presenting when the patient is, 60 minutes when the patient is presenting in the primary PCI center is a quality indicator. But still, if the patient is reperfused, presenting in a primary PCI hospital beyond 60 minutes, as long as it is less than 120 minutes, the prognosis of this patient is thought to be better than undergoing a thrombolysis. So it's really important to make this difference. The strategy selection is based on these 120 minutes and the quality indicator in order to make sure that you are doing the procedure correctly is these 60 or 90 minutes that we have here in the right. Until what moment after STEMI or STEMI symptoms should we reperfuse routinely all patients? So this is clear that within the first 12 hours there is a class 1A indication to perform reperfusion in all patients. This was also presented in the previous guidelines, ideally by primary PCI, and only if this is not be possible to be undertaken within 120 minutes, this recommendation is for immediate thrombolysis. In the past, it wasn't clear whether patients presenting very early, these called early presenters, would benefit from thrombolysis in a shorter period of time than patients presented later on, but this was based on secondary analysis from clinical trials, and there was not an ad hoc trial evaluating this hypothesis that early presenters should undergo thrombolysis much more frequent than primary PCI. The STREAM trial was the only trial designed to address this question, and it was shown that there was no benefit or no superiority of thrombolysis in early presenters. So this is why, and this is another change, it's very important that any time within the first 12 hours, the strategy selection should be based on these 120 minutes, regardless the time from symptoms onset. So a patient presenting 45 minutes after symptoms onset, you should calculate this 120 minutes the same as the patient is presenting, let's say, at the 6 to 10 hours. After 12 hours, there is no role for thrombolysis, so is primary PCI the strategy selection, despite of the time from diagnosis to reperfusion. In those cases in which the patient is symptomatic or with hemodynamic instability or presenting with arrhythmias, no matter how later after STEMI diagnosis or after symptoms onset, the patient should undergo a primary PCI. This is a class of recommendation 1, but what to do with patients that are asymptomatic and they are stable and they are presenting later than 12 hours from symptoms onset. So from 12 hours to 48 hours, this clinical guidelines propose that these patients should be considered to perform primary PCI in these patients. Well beyond 48 hours, routine opening of an occluded vessel is not recommended any longer. So this is a significant change from the previous guidelines, because in the previous guidelines this limit was set in 24 hours, and after reviewing the literature and mainly after reviewing the BRAVE2 trial, Dr. Castrati was the principal investigator and he's here with us during this meeting, it was clear that patients presenting between 12 hours and 48 hours undergoing routine primary PCI, not only they have an increase in myocardial salvage, but also there seemed to be an increase in long-term survival. So this is why in these guidelines, patients that are asymptomatic should be considered to undergo primary PCI up to 48 hours. And this is a change from previous guidelines, as I mentioned. So as you know, even those patients undergoing thrombolysis, the strategy is a pharmaco-invasive strategy 1. That is that even these patients who undergo thrombolysis because it's not possible to undergo primary PCI within 120 minutes, and even in those who meet reperfusion criteria, all of them should undergo an angiography between 2 and 24 hours. This was also presented in the previous guidelines, but the class of recommendation previously was a class of recommendation 2A, and mainly based on several trials showing that this early angiography in all patients with successful thrombolysis is beneficial. Then the recommendation in these guidelines is a class 1 with a level of evidence A. So in all cases, even when there is a reperfusion criteria, the patient should undergo an early invasive strategy with an angiography. Also, there has been a slight change in the pharmacotherapy associated with thrombolysis. As you know, patients who cannot meet these 120 minutes should undergo immediate thrombolysis. I have repeated this several times. This thrombolysis should be implemented within 10 minutes from STEMI diagnosis, and this is different from the previous guidelines in which this timing was 30 minutes from first medical contact. And in these patients, in the case that tenecteplase is the thrombolytic to be used, which is the recommended one, in those patients who are 75 years or older, the dose should be reduced by 50%. And this is mainly based, again, on the STREAM trial, in which the excess intracranial bleeding associated with thrombolysis was significantly attenuated after a change in the protocol, exactly modifying the dose in patients with 75 years of older age. So in these patients undergoing thrombolysis, not only clopidogrel should only receive one dose of 75 milligrams without loading, but also the dose of tenecteplase should be reduced by 50%. Also, there has been an interesting change, because we have all been trained, especially those who are older, by the different therapies for myocardial infarction, the morphine, oxygen, etc., etc. But there was no clear evidence that routine oxygen therapy was beneficial to these patients. But still, most or 95% of the patients, regardless of the oxygen saturation, they always receive oxygen therapy. So this has been a significant change, mainly based on 2 trials. The largest one is the Detox Trial, in which patients presenting with myocardial infarction, 3,000 with ST elevation myocardial infarction and 3,000 with non-ST elevation myocardial infarction, they were, and with a saturation of oxygen more than 90%, they were randomized to routine oxygen therapy or no oxygen therapy. And as you see, there was no difference at all in the clinical events. Also, there was a small trial, the AVOID trial, in which there was even a trend for larger infarctions with routine oxygen therapy. So this is why in these guidelines, to implement routine oxygen in patients with saturation 90% or above is a class 3 recommendation, and as I mentioned, this is a significant change from the previous guidelines. Also, which arterial access to perform in a primary PCI. It was also recommended to use radial approach, but with a class of recommendation 2A, and mainly based on this matrix trial, this recommendation has been upgraded to a class 1 indication, as I will mention later on. So this matrix trial that the principal investigator was Marco Balgimigli, these were almost 8,000 patients, half of them with ST elevation myocardial infarction, undergoing primary PCI, who were randomized to receive radial access or femoral access. And as you can see here, there were 2 co-primary endpoints, and the radial access was associated in both cases to a significant reduction in adverse cardiovascular events. Even if you see here, total death or all-cause death was significantly reduced in patients undergoing primary PCI via the radial access. So this is why, in this figure of the changes between the previous guidelines and the present ones, radial access was upgraded from a 2A indication to a class 1 indication, provided that this is done by operator that is proficient in this arterial access. Also, which stent type to choose in patients undergoing primary PCI. There are several trials, and I'm going just to be presenting the 2 largest ones. This is the examination trial that also the principal investigator was from Spain, Dr. Manuel Sabaté, in which patients undergoing primary PCI, they were randomized to receive bare metal stenting or drug-eluting stenting. As you see here, there were 2 different follow-ups. The primary outcome was based on the 1-year follow-up, and also there was a pre-specified 5-year follow-up, and the use of drug-eluting stents was associated with a significant reduction in stent thrombosis at 1 year, as you can see here, and also it was associated with a significant reduction in heart endpoints at 5 years. So it was clear that drug-eluting stents are superior to bare metal stents also in this context of a primary PCI. and also there was a second large randomized clinical trial using a different type of drug-eluting stents, all of them second-generation drug-eluting stents, in this case the comfortable MI, in which again the routine use of drug-eluting stents was associated with a significant reduction in adverse cardiac outcomes. So mainly based on these trials and to another one, also there has been an upgrade to use drug-eluting stents from a class 2A to a class 1 recommendation. I'm not going to spend a lot of time in how to manage non-infarct-related arteries. Yesterday we had discussion, and I'm pretty sure that during this meeting we will discuss much more, but just to present how this has been significantly changed from the previous guidelines. So as you know, patients presenting with STEMI, they have most of the times an occluded vessel or almost occluded vessel, but in a small proportion of patients, there are also significant lesions in arteries that are not the infarct-related artery. In the year 2012, there was not a recommendation to perform complete revascularization, provided the patient was not in shock. So the recommendation was to do only the infarct-related artery. But since the previous guidelines, there have been many studies. I am presenting here the 4 main trials in which we based our decision to change the recommendation. These are the PRIME trial, CULPRIT trial, DAPT trial, and COMPARE-ACUTE. I'm not going to go through this complex slide, which is here just to show that there's a lot of heterogeneity between the different trials. Some of them they did the all complete revascularization during the index procedure. In another trial, this was staged. In some cases, the trigger to do a non-infarct-related PCI was based purely on angiography. In other cases, was based on FFR. But in the end, the bottom line is in all of them, the composite endpoint was significantly reduced by performing a complete revascularization, even though we have to mention that this was mainly based on the reduction of subsequent revascularizations. So this is why in these 2017 clinical guidelines, all patients with a multivessel PCI, complete revascularization should be considered class of recommendation 2A, anytime during hospital admission, either immediately during the procedure or staged during hospitalization. And also you might say, why during hospitalization and why I cannot delay 3 or 4 weeks to do the non-infarct-related arteries PCI? And I would answer that I completely agree with this comment, but this recommendation is based on the 4 trials, and in the 4 trials, the non-infarct-related arteries PCI were done always during hospitalization. Also, and this is something extremely interesting, that we kept the recommendation to perform complete revascularization during the index procedure in STEMI patients presenting with shock. This was a 2A class of recommendation 2A with a level of evidence C, but 2 months after the release of the clinical guidelines, there were presented the results of the CULPRIT shock trial by Holger Thiele, who unfortunately he cannot join during this meeting because he was a father past days. And in this case, these were patients presenting with ST elevation myocardial infarction and having a multivessel coronary artery disease, so significant lesions in non-infarct-related coronary arteries, and they were randomized to receive complete revascularization or infarct-related artery only during the index procedure. And as you can see here, complete revascularization was associated with a significant increase in death. This was mainly based on the duration of the procedure, the contrast, and so on, but in any case, it was demonstrated that a routine complete revascularization in patients with ST elevation presenting in shock is not a good strategy. So this recommendation is already outdated 2 months after the clinical guidelines, and we can discuss this later on. So thrombus aspiration is also another example of bouncing in recommendations. As you know, in previous guidelines, this had a hold class of recommendation 2A to perform thrombus aspiration routinely in patients with ST elevation myocardial infarction, but since the publication of the previous guidelines, there have been 2 very large trials addressing whether this routine thrombus aspiration was beneficial for patients or not. This is the TASTE trial published in the year 2013. More than 7,000 patients with ST elevation myocardial infarction randomized to routine thrombus aspiration or not routine thrombus aspiration, and as you can see here, there were no differences at all in any of the clinical endpoints. And the second large trial, even larger, this is the total trial published in the year 2015, same design, ST elevation myocardial infarction patients randomized to routine thrombus aspiration or not routine thrombus aspiration, and as you can see here, again, there were no differences at all in the primary endpoint. And beyond that, there was a sign of even some side effects associated with routine thrombus aspiration, because as you can see here, the incidence of stroke was significantly higher in patients undergoing routine thrombus aspiration. There are many aspects about this that we can discuss later on, but in any case, it is clear that routine thrombus aspiration is no longer recommended. So from a class 2A indication in 2012, it was moved to a class 3 indication. So routine thrombus aspiration is not recommended in ST elevation myocardial infarction patients. I'm not going to go into details about which anticoagulation regimen to use. I will just summarize that after many trials and after many observational data and so on, we have come back to the origins, I would say, and the anticoagulation regimen to use is unfractionated heparin, and there are two valid alternatives that are enoxaparin or bivalirudin. But again, the best choice is to use unfractionated heparin. How to treat patients with acute heart failure and cardiogenic shock. This is a zone that we call the super level of evidence C, because there are not many trials addressing many of these questions. And in general, I would not go specific into each of these recommendations, but there has been a significant downgrade of most of these recommendations. So opiates from class 1 to class 2B, inotropics from 2A to 2B, ultrafiltration from 2A to 2B, and so on. Also important to remark that routine use of intra-aortic balloon pump is not recommended, it's a class 2 recommendation, and this is left for patients with mechanical complications, at least as a routine strategy. Also in these guidelines, not only we want to deliver simple messages, but also to make life easier to physicians. So this is why that same-day transfer of a patient to a referring hospital, as provided the patient is stable, is a class 2A recommendation. Previously it was a 2B recommendation, but this has been upgraded. This does not mean that the patient should always go back to the referring hospital, but in the case that the primary PCI hospital wants to bring back the patient, this is completely allowed, 2A indication. And also the early hospital discharge, which was a 2B indication in 2012, has been upgraded to 2A, and also this has been even moved to 48 hours after ST elevation myocardial infarction. Finally, we will have another session in which it will be presented different strategies to increase adherence to therapy, which is of great concern. And in these guidelines, we incorporated the recommendation which was already presented in the prevention guidelines from the 2015 ESC prevention guidelines for the use of a polypill strategy to increase adherence in patients after myocardial infarction. Lipid-lowering therapy, and this is my second last slide. I know Héctor has already put some pressure on me. So, as you know, it was recommended already in 2012 to use high dose of statins with the goal of an LDL of 70 milligrams per deciliter, or at least a reduction in 50%. But in this case, this was the first guideline to incorporate the data from the using ezetimibe and also using PCSK9 inhibitors. And in these patients in which, despite maximally tolerated statins, you cannot reach this goal of 70 milligrams per deciliter of LDL, these patients you should consider to use an additional lipid-lowering therapy. I'm not going to go into detail, just to propose you or to encourage you to go to the figures or the set of figures that we have in the guidelines, because they are not only very didactic, but also very practical. For example, if you go for primary PCI, you will have here all the recommendations holding a class 1 or 2A recommendation, and also in a timely manner. So I just want to finish by thanking your attendance, and most probably we'll have a lot of discussion later on. Thank you very much.
Thank you very much, Borja, for sticking to the time. I'm sure that there must be a lot of questions and comments regarding these guidelines. I think this is having a fascinating work. But I think we will continue, and perhaps at the end we can have a discussion with all the guidelines. So the second one will be the update on the DAPT management with Francesco Costa will be presenting.
Thank you, Mr. Chairman. Ladies and gentlemen, good morning. So it is a great privilege and honor for me to be here on behalf of Marco Valgimigli, the chairman of these guidelines, and also thank to the members of the task force, which are a group of well-renowned researchers and physicians that in 3 years of intense work had condensed all the evidence with respect to the APT duration in patients with coronary artery disease in this document. So the focus of these novel guidelines in the family of ESC guidelines is the impact of DAPT in patients with coronary artery disease. And we know that DAPT has been introduced since more than 20 years now, for the first time in the ESR trial, with the association of aspirin and ticlopidine. And in these years, after more than 35 randomized controlled trials and more than 200,000 patients included in studies, DAPT is one of the most explored treatments in cardiovascular medicine. And especially in the last 20 years, it has changed a lot our understanding of which DAPT represents, that has been introduced like a treatment for stent-related complication and is now considered a fully blown secondary prevention treatment for all thrombotic vascular complication across the board. In these guidelines has been revised all the prior recommendation for the DAPT duration of prior ESC guidelines, and the document is formed with change in recommendation and with new recommendation, and also with new revised concept and tools for clinical decision making. So let's start with a change in recommendation that has been introduced with the novel version of the guidelines, in which now pre-treatment with the P2Y12 inhibitors, when PCI is planned, is a class 1 indication. This is basically represent the attitude in patient with STEMI or in which coronary anatomy is known and the decision to proceed with PCI is already made. With respect, another big change in guidelines is the approach with respect to PPIs. Now PPI is a class 1 indication and is indicated to all patients that are treated with DAPT. And this is mainly changed by the presentation of the Cogent trial, in which there was a dramatic benefit from association of PPI in association to DAPT, especially with respect to gastrointestinal and overt gastrointestinal bleeding. There has also been a change with respect to the minimal delay for elective surgery in patients treated with coronary stents that is now been informed by a large Danish registry and other registry data. And there has also been an update of the recommendation regarding dual therapy, which has now been reinforced with other trials, most importantly the Pioneer AF-PCI trial, and now dual therapy consisting of a P2Y12 inhibitor and associated with an oral anticoagulant is a class 2A indication, recommendation. There are also new recommendations in these guidelines, and most importantly, as this general statement, the decision for DAPT duration should be dynamic and reassessed over time, taking into consideration the complication of the patient, so the presence of minimal or major bleeding, for example, and also the change of the risk over time of the patient. There is also a novel concept regarding a shortening of DAPT duration in patients with acute coronary syndrome if these are deemed a high bleeding risk. And finally, after the presentation of the Pegasus trial, there is also an opening of extending DAPT beyond 12 months using ticagrelor. We will talk about this in detail further on. There are also new revised concepts, and for the first time in ESC guidelines, there are some clear indications with respect to switch of P2Y12 inhibitors, which are represented in this cartoon. So basically, the switching algorithm is divided in two different scenarios. An acute setting, which is mostly related to the in-hospital stay of the patient, in which is very easy to remember, it's always reload. So in this setting, all the patients that are switching from one drug to another should always be reloaded. This is different for the chronic setting, which is represent mostly the out-of-hospital setting, in which the loading dose should be administered only in the case we are stepping away from ticagrelor, so in the transition between ticagrelor to prasugrel or ticagrelor to clopidogrel. There are also new concepts with respect to risk scoring to guide the DAPT duration, and in these guidelines there is a new recommendation regarding the possible use of a dedicated risk score to inform decision making for DAPT duration. And these two scores are the precise DAPT score and the DAPT score, which have been validated in patients for decision making in patients randomly allocated to DAPT duration. So this is the flow chart that summarizes the approach to type and duration of DAPT across the DAPT guidelines. And there is a stepwise approach. So all patients with coronary artery disease, the first step approach is to clarify which is the strategy that is used, that can be revascularization with PCI or CABG or medical treatment alone. The second step is the clinical presentation of the patient. So whether the patient is a stable CAD or is an acute coronary syndrome. The first step is the device that has been used during percutaneous coronary intervention, which is not a driver per se anymore of DAPT duration, with the only exception for bioresorbable stents. And finally, the last point to consider is the presence or absence of eye bleeding risk, which is the real gatekeeper for DAPT duration in this novel version of the guidelines. So here is the approach to percutaneous coronary intervention in patients with stable coronary arteries and acute coronary syndrome. As in prior guidelines, stable patients are recommended, are indicated with 6 months of DAPT irrespective of the stent type. This is a class 1 level of evidence A recommendation. There is an introduction of a novel recommendation that is for shortening DAPT to 3 months in patients that are considered at high bleeding risk, as for example, those patients that have a precise DAPT score of 25 or more. In this case, a 3-month DAPT should be considered. There is also the possibility of further shortening this duration of treatment in patients in which also 3 months may pose excessive bleeding risk for DAPT. It's important to say, however, that as stated in the footnotes of this table, this evidence is coming from randomized clinical trials in which 2 specific stents has been used, so it is unclear if this recommendation also applies to other kind of stents. With respect to acute coronary syndrome, no big difference as compared to prior guidelines. The recommended duration of DAPT is still 12 months unless there are contraindications, for example, an excessive risk of bleeding. In this case, as stated before, patients that are considered at a high bleeding risk, the treatment could be shortened to 6 months. There are also new data that support extending DAPT beyond 12 months. And these are the 2 landmark trials that have been presented in 2014 and 2015, the DAPT trial and the Pegasus trial, 2 very big trials in which, for the first time, we had the power to see a difference for extended DAPT. However, the results of these trials have been controversial, mostly due to the trade-off between ischemia and bleeding. So there is the class of recommendation for extending beyond 12 months is a class 2B, so this may be considered, but only in patients who tolerated DAPT and who did not have bleeding during the first year of treatment. In this case, extending DAPT may be considered. There is also a recommendation regarding ticagrelor, as we said, introduced for the Pegasus trial, in which patients with prior MI and a high ischemic risk may be considered for a treatment with ticagrelor 60 milligrams twice a day as compared to clopidogrel or prasugrel. This is the algorithm for ACS patients treated with coronary artery bypass grafting and medical management. The message is pretty much consistent with the general ACS population with some slight difference. For example, in medically managed patients, a treatment with prasugrel is not recommended after the results of the Trilogy ACS trial, so the first-line treatment is still ticagrelor, or in patients in which there is a contraindication for ticagrelor, clopidogrel. And this is the novel scheme with respect to DAPT after PCI in patients with an indication for oral anticoagulation. As we can see from the plot, there are several different recommendations that are stratified based on the perceived ischemic and bleeding risk. On the extreme left of the plot, there is the situation in which the ischemic risk prevails as compared to the bleeding risk, and on the extreme right, there is the condition in which the bleeding risk is felt to prevail as compared to the ischemic risk. A more extensive definition on what is considered a higher bleeding risk or higher ischemic risk is fully disclosed in the paper, but in general, one big step forward that has been introduced in these guidelines is the novel recommendation for, an upgrade of recommendation for dual therapy, which now should be considered in patients in which bleeding risk prevails ischemic risk. In this case, the plot does not represent the class of recommendation, but instead the color coding represents the importance or the impact of the tripel therapy as compared to the dual therapy. So in general, it's other two important concepts to summarize that dual antibladder therapy should always be introduced during the PCI, so during the periprocedural period, aspirin should always be present, whereas after 12 months of treatment, only oral anticoagulation should be maintained with no further antiplatelet therapy. Another important concept that is discussed in the guidelines is that if novel oral anticoagulants are introduced, these should be used with the lowest approval dose effective for stroke prevention. So the dose which has been approved after landmark AFib trials. There are novel recommendations also with regard to the minimal duration of delay for elective non-cardiac surgery. So there is a red light for elective non-cardiac surgery in the first month after stent implantation, so this is a no-go, whereas there is an opening in the window between 1 and 6 months in which the interruption of P2A12 inhibitor should be or may be considered based on the ischemic risk of the patient that is mostly defined as the presence of acute coronary syndrome or some high ischemic risk features that are disclosed in the paper. In general, as in prior guidelines, in patients that can accept a delay for elective surgery of at least 6 months, this is a class 1 recommendation. So this is the way to go. In these cartoons, we present novel recommendation with respect to the minimal delay for P2A12 interruption before surgery, before major surgery. This slightly changed from prior documents, and this more resembles our prior knowledge of PK/PD data. And now ticagrelor can be stopped 3 days before surgery, clopidogrel at least 5 days before surgery, and prasugrel at least 7 days before surgery. P2A12 inhibitors should be re-implemented as soon as possible and as soon as deemed safe after surgery, and generally 1 to 4 days after surgery. And in general, all efforts should be made to maintain aspirin during the periprocedural period. There are also some recommendations regarding special population, and now the approach to DAPT type and duration should be similar for male and female patients, and also for patients having or not having diabetes mellitus. And there is also novel recommendation with regard to patients with prior stent thrombosis, especially if stent thrombosis is not due to a cause that is correctable. So in these patients, a longer DAPT duration beyond 12 months should be considered. Longer DAPT duration beyond 12 months may also be considered in a specific patient like those with peripheral arterial disease, and in specific case with the lower extremity arterial disease, and in patients with complex PCI. Again, the definition for complex PCI is fully disclosed in the paper. I also suggest to see this companion document of the guidelines. There is a case-based implementation of this novel recommendation in which in which physicians from around the world sent real-world cases that has been evaluated by the task force member and in which the novel recommendation has been applied. This is a very good translation and practical outlook on how the novel recommendation impact on real-world cases. And thank you very much for your attention.
Thank you, Francesco. First, I forgot to introduce Francesco. I'm sorry for that. He's an interventional cardiologist, and he's based now in the Hospital Clinic in Barcelona. That's the formal presentation. The informal presentation is that in every guidelines, there's of course the chairs, and there's a few persons who are really the spirit of the work of this big group. And there's a lot of work, there's a lot of, and Francesco was the spirit of these guidelines, I can tell you. He's also a little bit of the artist of these fantastic graphs that you have seen in these guidelines. So Francesco has been absolutely essential in these guidelines.
We are going to move now to the third session, which is about valvular heart disease, which all of them are extremely interesting, but as you know, recent evidence for the treatment of patients with valvular heart disease make this even more interesting. And we have the privilege of having Pilar Tornos from Barcelona, who has been very active in different clinical guidelines for valvular heart disease, and also we will see her speaking later with endocarditis. So it's going to be a real pleasure not only to hear about the guidelines, but also to hear her inputs about how was this prepared and the discussions that you had during the presentations.
Thank you very much. It's for me really privileged to be here on behalf of the task force members. So I thank the organizers for inviting me. As you all know, valve disease in the valvular guidelines are not only the guidelines for cardiologists, but also for surgeons, because both societies, the European Cardiac Society and the Society of Cardiac Surgery, were involved. That means that in the task force there was a tough discussion between interventional cardiologists, surgeons, and clinical cardiologists. The points that were really stressed in these new guidelines were the importance of heart valve centers, on which very difficult patients with valve diseases should ideally be treated. That means centers with experience in intervention, with good surgeons, and with clinical cardiologists. Also, the transcatheter techniques were also discussed deeply. There was changes also in the indications for surgery in asymptomatic patients, and also changes in anticoagulation and antithrombotic therapy, although we endorsed the document that we have, Dr. Costa has already discussed. Going to aortic stenosis, the most relevant changes between those guidelines and the previous one were one regarding low gradient aortic stenosis, on which the role of calcium scoring by CT scan in diagnosis promoted a change in surgical indication. There have been changes also in the surgical indications in the asymptomatic, and also there was a tough discussion between TAVI and surgery, as you can probably imagine. We all know that the diagnosis of severe aortic stenosis, it's normally easy by echocardiography and Doppler, but sometimes this diagnosis is extremely difficult. We think that the calcium score by CT scan, it's a tool that can allow to clearly differentiate between severe and non-severe aortic stenosis. And there are many studies that really show that, excuse me. Oh my God. There are many studies that really show that if the calcium scoring is over 3,000, the likelihood of severe aortic stenosis is very high. And on the other hand, if the calcium scoring is less than 100 and 600, the likelihood is very poor. That means that in very difficult cases, we can use this score to rely on the severity of the disease. And that means that in the very difficult cases of aortic stenosis in patients with low flow, low gradient, reduced ejection fraction, in which the diagnosis is very difficult. In the previous guidelines, there was a 2B indication in these patients. And the reason that there was a 2B was that we were not really sure sometimes if we were sending to surgery patients who really have severe aortic stenosis. By adding the calcium scoring, we are more reliable in our diagnosis. And that means that if we have a patient with low flow, low gradient aortic stenosis, even if the contractile reserve is not good, but the calcium scoring really points out towards severe aortic stenosis, we can proceed to surgery more freely. And this has been moved towards a 2A indication. In fact, that's what our friend Catherine Otto said many years ago. In these very difficult cases of severe aortic stenosis in which you are not sure of the severity by echo and Doppler, she always said, look at the valve. And what we are doing by CT scan is looking at the valve, not through our naked eye, but through a CT scan that can provide and quantify the calcium, and the calcium is really related to the severity of the disease. There were also changes in the indications in the asymptomatic. Especially, we relied very much on natriuretic peptides, because there have been several papers that really suggest their important role in prognosis. That means that in patients with severe aortic stenosis with markedly elevated VNP levels, there was a move in the indications from a 2B indication to a 2A indication, and I think that this is important. And also one of the issues that really provoked more controversy and discussion, sometimes tough discussion between intervention cardiologists and surgeons within the task force, was the discussion between TAVI and surgery in patients with severe aortic stenosis. The task force decided not to give indications for one thing or the other, but provided a list of aspects to be considered by the heart team in order to decide in each center which was the best therapy for the patient. However, there were big movements, like as you can see here. One of the important things is that intermediate risk patients were considered that if the risk of a patient is more than low, that means it's moderate or severe, this favors TAVI, and also favors TAVI an age over 75 years. You can say, why did you choose 75 years? Because there is no evidence available whatsoever. It was a discussion between the task force, and it was a decision of the task force, so you can take it as it is. This really is a big change. Another important aspect is that the access through transfemoral approach is important, especially in patients with low risk and moderate age. If you are going through TAVI, you need to be sure that the transfemoral can be used. The other aspects to be considered were already there. I mean, you have anatomical and technical aspects that favor TAVI because patients cannot be operated on because they have such radiation of porcelain aorta or severe chest deformation. That was already in. And on the contrary, if you have contraindications for TAVI because of valve morphology of thrombi or size of the aortic valve or severe coronary artery disease requiring revascularization, then of course you will favor valvular replacement. And also if other valvular diseases are there, you would consider surgery instead of TAVI. I think that the most important thing that was incorporated in these guidelines is that TAVI can be considered for patients with intermediate risk, and also that TAVI can be considered in patients over 75 years of age. The intermediate risk is based on clinical trials. As you know, there are clinical trials that really suggest that TAVI in the intermediate risk is at least as good as surgery and probably better than surgery if the transfemoral approach is used. But I can admit that the limit of 75 years was really a consensus of people within the task force, no more than that. What about aortic regurgitation? In aortic regurgitation, the methodology for aortic measurements using CT was stressed. There are no changes in the surgical indications for aortic regurgitation, which is based on ejection fraction and volumes, as was before. The role of aortic valve repair is reinforced, and it was a big fight for the surgeons who really wanted to push aortic valve repair in these guidelines. And there have been some changes in the surgical indications in some cases of combined valve and aortic disease. The surgeons really pushed a lot for valve repair, for aortic valve repair. There was a big discussion because, as you all know, good surgeons in good centers have good results with aortic valve repair. But aortic valve repair is not universally available, and on top of that, there are not really still papers on long-term results. Therefore, what we decided to do is to push as a class 1 indication the consideration of performing aortic valve repair. That means that there is a class 1 indication that a heart team discussion is recommended in selected patients in whom aortic valve repair may be a feasible alternative to valve replacement. That allows that people who are good surgeons who can do valve repair that have good results, they can go for it. And aortic valve repair acquires visibility within the world of valve diseases. And the second thing that changed, as I already told you, is that there are some changes in patients with combined valve disease and aortic disease, in which, especially in those patients, we have Lloyd-Dietz syndrome or mutation of fibrillin 1 or 2, in which surgery can be considered when the aortic diameter is greater than 45 instead of 50, as it was in the previous guidelines, because some papers have appeared regarding expressing the bad prognosis of these particular genetic diseases. In mitral regurgitation, there had been a change in the surgical indications in asymptomatic MR. There have been changes in the surgical indications of secondary MR, and there has been no change in mitral clip indication, which still is a 2B indication in patients with primary or secondary MR and ejection fraction less than 30%, with persisting symptoms under medical treatment and resynchronization therapy if indicated. The reason is that there are still no results of trials showing that good outcome results and long-term results are provided by mitral clip. The change that has really been pushed by especially by the Mayo Group people and the results of mitral regurgitation is that in patients with asymptomatic mitral regurgitation with normal ejection fraction, with normal and systolic diameter, surgery can be offered as a 2A indication, provided that the repair is performed in half-valve centers. That means that we go for an earlier surgery in severe mitral regurgitation. Clinicians were a little bit worried about pushing this indication towards a 2A indications because it might happen that patients with non-severe mitral regurgitation can be offered. That's why we thought that it was important in this setting to be sure that mitral regurg is really severe, and probably the presence of significant LA dilation can be a clue towards that. In secondary mitral regurgitation, there was a big change after the trials that appear in the New England Journal of Medicine, is that in patients who are submitted to bypass surgery and who have moderate secondary mitral regurgitation, it was in the previous guidelines, surgery was considered, I mean putting a ring on the mitral valve. But after these two papers that appear in the New England, this indication has been removed. That means in patients going to surgery for bypass surgery with moderate mitral regurg, to put a ring on the mitral valve is no longer considered. Finally, regarding prosthesis and anticoagulation, there have been changes in the role of new oral anticoagulants in valve disease. And there have been also changes in the antithrombotic treatment, but Dr. Costa has already alluded to that, because in the task force, we simply endorsed the document by Dr. Costa's group. The change with the new oral anticoagulation is as follows. We can freely use all oral new anticoagulants in patients with valve disease and patients with bioprosthesis. In the only setting in which the new oral anticoagulants are not allowed so far are in those patients with the highest risk of embolism, that is, patients with mitral stenosis in atrial fibrillation, and in patients with mechanical valves. In mechanical valves, we are supported by one clinical trial in which the new oral anticoagulants were supposed not to be protective, although this trial can be very much discussed, but this is the only evidence we have. So the new oral anticoagulants so far are not allowed in patients with mechanical valves. In patients with mitral stenosis and atrial fibrillation, there are no trials whatsoever, but we know that the risk of embolism is very high, and the task force decided to keep on warfarin in those patients because there are no trials. And this is my last slide. There are other aspects which were new in the guidelines. That's the importance of the role of self-control of anticoagulation in patients with mechanical valves. And this was considered to be a class 1 indication. There are several trials that have really stressed the security of the self-control of anticoagulation, and I think that we all should move towards this. The role of percutaneous leak closure was added in the guidelines. It was not in the previous guidelines. It's a 2B indications in selected patients with leaks. And the role of valve-in-valve procedure was also included with a 2A indication. And that's all. I think that those were the most new aspects of the valve team.
We're going to ask speakers to join us for the discussion. So I think this is open for discussion. We have microphones there, so please raise your hand. And it's a great opportunity to have here members of the task force. So there are many aspects that are certainly controversial, and also maybe you would like to know which were the backstage happening. In the meantime, we have two questions here. Okay. There's another one. Yeah.
Yes, thank you very much for this perfect presentation. Mr. Ibáñez, I have a question for you. You mentioned that in one of your slides that the radial axis has a less or lower cardiovascular death than a radial. I cannot explain why. Could you give us an idea?
This is mainly based on bleeding, so most of the clinical events reduction driven by the radial access is driven by bleeding. So even though the total mortality was also, we had a reduction in non-bleeding mortality, this is not fully explained by, as you know, that what would be the mechanism by which radial access would reduce non-bleeding mortality. But in any case, there was significant reduction in bleeding, and this was associated with a reduction in mortality. But
So it's just an experience.
Yes.
There's no explanations. So not
Exactly,
clear. Yeah.
yes. For the non-bleeding reduction, there is no clear
Okay.
explanation.
And Mr. Costa, second question about the duration of the dual antiplatelet therapy. We never, as an interventional cardiologist, we never mention the complexity of the stenosis together with the duration of necessity of dual antiplatelet therapy. Shouldn't we consider also if we have a long stenosis with a small vessel, 2.5 vessel, or even a bifurcational stenosis, shouldn't we consider also the morphology of the stenosis together with the necessity of duration of the dual platelet therapy?
Yes, yes, it's a very good point indeed, and I think it's of utmost importance. And in a way, it has been introduced for the first time in these guidelines, the impact of PCI complexity. This comes from a very nice article that has been published in 2015 in JACC by Gennaro Giustino in New York, and this shows that in patients with some complex PCI criteria that are, for example, more than 60 millimeters of stenting, bifurcation stenting with 2 stents, a CTO treatment, 3-vessel disease treated with 3 stents or 3 lesions. These are all characteristics that increase the ischemic risk that is directly related not only to the stent, but also to the overall patient risk, because a patient that has a higher complexity of the anatomy is also a higher complex patient. And it has been demonstrated that in this case, prolonging the APT, not at 6 months, but to 12 months, has a significant benefit. But it is also associated with a significant bleeding liability. So I think that this is quite challenging in the case you have a patient that is both considered a high bleeding risk and with a complex PCI. So I think that in general, if we can avoid the complex PCI, would be better in difficult patients, but in case we have to stick with that, a longer DAPT may be protective.
This question is for Francesco. As you know very well, there are many, but some trials running right now, or some trials just planned to be running in the near future, addressing the high bleeding risk patient, because all the companies want their stents to have the indication for 1 month DAPT, competing with BioFreedom, with the Leaders 3. And the criteria for high bleeding risk is just, for example, to be over 75, which is the most common indication met for the patients in the trials. This means that maybe we are denying in the future the benefit of anti-thrombotic protection elderly patients just based in a, for me, misleading conception of high bleeding risks. You know, for example, in Leaders 3, 60% of the patients included in the trial were just considered to be high bleeding risk because of the age of over 75. But all of us see patients every day. I am interventionalist. We are implanting stents in patients 77, 80 years old that they are not at high bleeding risk. Maybe they are at mid or even low sometimes. Then we are now pushing to put the DAPT so low, so short, that maybe we are moving to the pendulum from the 12 months we have just 4 years ago to the 1 month now. And we have complex PCI in these patients many times, for example, and a lot of co-acute coronary syndromes. What is your idea of this? How to put some, maybe to use your score to really define what is the high bleeding risk? Because the criteria in the trials is just age, for example, over 75.
Well, yeah, I totally agree with you. I mean, it may be a pity only to rely on age, because we can have 80 years old patients that are perfectly fit, that are, well, in better condition than 65 patients with multiple comorbidities. So I totally agree with you on that. I mean, in general, I think that relying on more granular evaluation of the risk may be better, may be more complete. We have data from multiple individual patient meta-analysis in which age is a treatment modifier for DAPT duration. I mean, this is something that we can expect in the majority of patients. Majority of older patients do not stand longer DAPT, but in general, I think that should be some patients that are fit that could be addressed with a longer treatment duration, which might reduce the ischemic risk without increasing excessively bleeding risk. I agree with that. There is a lot of pressure by the industry on that in order just to put the label to see that they can stand that kind of DAPT, so the market is going that direction. But still, I think that with the data that we have with regard to a longer treatment and all around the board vascular protection in some patients, that might be a pity. So I totally agree with you, and I'm fully for a more extensive evaluation of the patient, so not relying only on one data.
Okay. So I have a question for Pilar Tornos on TAVIs, and it's not going to be about the cost of TAVIs for once, and it is about, so my concern is about TAVI implantation in younger patients. So I totally agree with the guidelines that if you have like an 85-year-old without frailty, it does make sense to prefer TAVI over surgical aortic valve, just because his recovery is so much quicker. And but what about younger patients? Because my concern is about that many of them will end up with a TAVI and the pacemaker, which is a major problem in patients with calcified aortic valves. So I'd like to hear your opinion on this.
Well, as I said, there was a big discussion between the team, because there were interventional cardiologists, German interventional cardiologists that, as you know, they are very much in favor of TAVI. And I think that this issue is really difficult. However, pacemaker, it depends on the type of valve you use. I mean, if you use the Edwards, the incidence of pacemaker is not that high. It's not that high. So it really depends, and you have to address it's not the issue in our country. We cannot ask the patients to decide what they want. But in many places, it's like that. I think that the issue of 75 years was very much discussed. And I really don't know, but there are many patients that if they are 75, they have intermediate risk, they have very good femoral access. I think that TAVI is a good choice. Why not? And I think that the world is going in this direction. And I'm sure that it will be even more when the new data on low risk will appear very recently. If the transfemoral is good, why not? Why not? Because I don't think that the pacemaker is really a problem if you use the correct valve.
So now that the wound is open, can I ask one more question, just very quick? And it's about TAVI implantation in centers without cardiac surgery. So I'd like to hear your opinion and on this very hot matter.
I know that it's a very hot matter. In the guidelines, we decided to stick on that. There is one reason. It's not because TAVI patients may have complications that need urgent surgery. This is very unlikely to happen then. But we think that TAVI should be performed in centers, in heart valve centers. That means with clinicians, with interventional cardiologists, and with surgeons. I mean, and the discussion should be individualized, and each patient has the right to be discussed by the whole team. And I think that that's the reason. I mean, this doesn't mean that you cannot perform TAVI valve in a center without surgery, because you can have heart valve teams which are virtual. I could agree with that, of course. But the rationale is not to because of problems that may appear, but because the decision should be discussed within the team.
So Pilar, I mean, just on this topic, I think the discussions that you had in the guidelines actually have become a little bit of a battlefield in real life. And I think it's implicit in the guidelines, but I'm not sure that the understanding is so wide, and I would like you to say it clearly, because it is not as clear that a transfemoral TAVI is superior to transapical TAVI. That would be the order to decide. Is that the case? Is not? Because, I mean, now there's a lot of discussion whether actually which patient should go to transfemoral, to transapical. Transapical should only be done in those who do not have really femoral accesses. Could you please clarify that? Because I think the guidelines didn't put it as clear as probably people would have wanted.
Yeah. I think that what is in the literature is that in the intermediate patients, the results of TAVI were better than surgery if the transfemoral access was used. And I think that makes sense. In my opinion, and I think that I can translate the majority of the opinion of the people of the task force, is that transapical, transaxillary or whatever should be used for those patients who really cannot go to surgery. But if not, I think that the results of the transapical or transaxillary or whatsoever are not better than surgery at all. So that means that you can probably you have to go for TAVI very happily if you have the transfemoral. If not, really you have to reconsider it and see really whether surgery is probably a better option.
Coming to this, I would like also to ask Pilar about this controversy about the cardiac surgery or cardiac surgeons or cardiologists. So in Spain, we're having a very interesting situation in which cardiac surgeons, eventually at the very beginning, they were not happy with the TAVI procedures and so on. But lately, they want to incorporate this into their portfolio of actions that they can make. So there was any discussion about who should perform the TAVI procedure, if this should be done by interventional cardiologists, or eventually in different countries, cardiac surgeons take even a similar role to interventional cardiologists.
No, there was not such a discussion, but I think that surgeons should be in the team. And if they know how to perform it, why not? I mean, it was not in the discussion. But I think that the important thing is the team. And why are interventional cardiologists doing it instead of surgeons? It was like this. Why the cardiac catheterization is done by cardiologists and not by radiologists? Just because they knew how to do it, and they do it. I don't know. I know that there are many surgeons who are now getting more and more involved in intervention. Of course, they need to, probably.
Yeah, this is a question also for Pilar Tornos. It's regarding the heart team that is recommended to have these meetings in the guidelines, but we are all very busy, and you know that it's difficult to meet together every week, or every day, clinicians, surgeons, and interventionalists. So the question is there is any discussion on the profile of certain type of patients that may go straight to TAVI without discussions, maybe because of the age or the profile, without, going to the heart team discussion.
I think that this is probably a common sense. I mean, if you have a patient who the clinician considers that it's not operable because of comorbidities, you can go. But I think that every patient has the right to be discussed properly. And if you don't have the time, we'll have to find it. I'm sure, I think that it's our responsibility. And I think that it doesn't mean that we have to be together. But if I am the clinician, that's responsibility mainly of the clinic, of the clinician, who really needs to have the best for his patient. So if he cannot have the surgeon and the interventional together, he has to move and go to the surgeon and go to the intervention and then decide what to do. I'm stressing the role of the clinical cardiologist, which I'm afraid is being loose. And I think that's the most important. Because if you cannot have the surgeon and the intervention in the same room discussing the patient, it's your responsibility to go and seek what's the best option for your patient.
My question is for Pilar Tornos, is regarding valve regurgitation. There are many indications in which this surgery should perform in a specialist center. How to consider a cardiac center expert in valve repair? Did you discuss about that, a cut-off number of procedures, or?
No, we were discussing it, but we didn't put it in. I think that it's something that needs to be done, as it has been done in mitral valve repair. As you know, there were a lot of surgeons who were really pushing. It was Emmanuel Lanzac who was really in the team just pushing for aortic valve repair. And he wanted to be that, I'm sure that he considers that the team was perhaps too conservative. But we thought that, you know what guidelines are? I mean, guidelines are applied all over the world. And you cannot put aortic valve repair as an indication, class 1, for some patients when you know that there are many, most centers in the world who do not have surgeons who can really do it. So what we decided is just to visualize that aortic valve repair is there, to visualize that this as a class 1 indication. That means if you have a patient with aortic valve repair, with aortic root dilated, valve repair should be considered. And if you can do it, because your surgeon offers you good results, go. But we didn't put the numbers in order to select which centers will be recognized as good ones for them.
So let's give Pilar a little bit of a break. So Borja, there's been a lot of controversial issues well, there's always controversial issues in all guidelines. I'm curious about, this is not exactly about the evidence, it's about the transition, because at the end, the biggest challenge in the guidelines is the implementation phase. And I'm surprised that, for instance, some of the real strong decisions like thromboaspiration, balloon pump in cardiogenic shock, which are clear C3 levels, are really still very popular, and they're very much used. What do you think is that discrepancy between, let's say, this thorough thinking and definition in the guidelines, and then this difficulty in getting implemented in real life?
Well, this is a very, very relevant question. There are some interventions that are recommended with a class of recommendation even 2A or 1 that are not widely implemented. And this might be because of some previous perceptions, and despite they are not implemented. But what is much more interesting and much more important is the change in the recommendation. So as you mentioned, for example, thromboaspiration was recommended, was widely used, and despite now is no longer recommended, for some people it's really difficult to move away from what they are used to do. So especially interventional cardiologists, you work mainly as air reflex, and you have your procedure, it is going well. Everyone has their own experience, and they think that, okay, in my own experience, this is okay. So I think it's much more difficult to change something that is already widely used than to incorporate new things. Even eventually you might have some trial, like for example the culprit shock, in which something is not useful, like thromboaspiration, but something is harmful, and I think this is incorporated much faster. But in any case, there are some recommendations that there is a change because it's no beneficial, so no benefit, no harm. But in those cases, many interventional cardiologists or even clinicians for therapy say, okay, this is not harmful, I have my own experience, and I'm going to keep on doing this. So these changes take much longer time.
Yeah. Francesco, we were lucky because, I mean, you mentioned the discussions with the surgeons. Actually, we were very lucky with the surgeons in our team, and we didn't have big discussions. We have extremely strong discussions, but actually not with the surgeons. We were about within the cardiologists. But this is not my point. My point, and it comes to Pilar's point, I'm biased because I'm a clinical cardiologist, but actually the philosophy of the DAPT guidelines is that DAPT is not a treatment for stents. But actually the majority of the task force are interventional cardiologists. That's the same for STEMI. And I'm a bit worried, well actually very worried, that there's a trend in cardiology that TAVIs, stents, these decisions are really driven by interventional cardiologists, which actually, I mean, it has to be integrated in a broader view, and I'm not sure, and these treatments are not for stents, because actually half of the acute events are not stent related. So I'm not sure whether there should be a change in the protagonism of clinical cardiologists in the guidelines, task forces, I'm challenging you too. We're half and half, which is quite unusual.
Well, yeah, this is true. I mean, it's there was a vast majority of interventional cardiology in the task force. I believe that in a way, DAPT has been classically seen, and it is like this in the real world, that is the interventional cardiologist who should mandate the DAPT duration. So when the patient presents for the first time, and maybe with a stable coronary artery disease or with an ACS, there is a first time that the patient is getting DAPT, and after that, the patient remains attached. So I have a stent. So I am property of the interventional cardiologist, and this should not be the case. I mean, there are patients that may have an indication in the future for 3 or 5 years of DAPT. There is no sense that the interventional cardiology get in that discussion anymore. But maybe there could be a domain of clinical cardiologists that see the patient more often, that evaluate the dynamic change of the risk of the patient, and reevaluate if the patient has to stay or should prolong even more DAPT. I don't know, what do you think about this? If you...
Yeah, well, I would like first hear Borja's view, because I think that I'm always curious that, again, there's a majority of interventional cardiologists which actually they play like 10, 15 minutes of the life of the patient with them, and all the time is with cardiologists, with clinical cardiologists. So I would like to hear your view, whether I'm biased or you're biased.
So I'm going to start first with the political answer, that I think it should be balanced, and you should have clinical cardiologists, cardiac surgeons, interventional cardiologists, and so on.
Political means.
But in the end, it is true that most of the significant reduction in mortality and morbidity associated with cardiovascular diseases have been driven by the wide implementation of interventional procedures. For example, primary PCI has shown to be significantly associated with the reduction in mortality, also early invasive strategy in ACS patients, non-STEMI, even early invasive strategy after thrombolysis. And most of these trials have been led by interventional cardiologists, who are those who are designing the studies and undertaking these trials. So this is why in the end, in the task force, you would like to have experts, but also if you have some cardiologists, interventional cardiologists, or whatever specialty that have been the drivers of the trials, you like to have their own experience. So I think this is one of the main reasons, and interventional cardiology certainly has changed the prognosis of patients with cardiovascular diseases. And I would say that it's only 15 minutes, maybe 1 hour if Antonio is doing the PCA, but still is not a long time. But most probably these are the 15 minutes that have a highest impact in the prognosis of the patient. This is the non-political answer.
Well, I have to say that you need a clinician to get the patient in the cath lab. You need a system to get them there, and then you have a proper treatment to get the stent open, the beta blockers, ACE inhibitors, secondary prevention, and so on. I think it's a much wider view on the full patient life.
And I forgot to mention something, that if I have the opportunity in this forum, is that we interventional cardiologists, usually we are blamed that we always want to implant stents, and we are very quick in implanting the stents. But in the end, most of the times, or many times, the clinical cardiologist is the one telling you, oh, do and go and stent in. Because in the end, if you have a severe lesion, you ask the interventional cardiologist, okay, let's discuss with the clinical cardiologist, and I would say that 95% of the cases, the clinical cardiologist say, oh, go and implant an stent, because otherwise, what I'm going to do when the patient is coming back and back with chest pain. So I think we are not the ones to be blamed here.
It's now becoming defensive. I mean, we're not blaming. We work very well. I mean, we know that's the real advances. But I think it has a wider view on the implementation of interventional cardiology, which has really changed. And I think that is the real example of how this is the second time, I would say, in life, PCI changed the world of revascularization. TAVI is changing the life of valvular disease, and probably will come with more advances with mitral and so on, I mean, when technical things like that. But I think have to integrate it in the real full perspective of the patient life.
I just would like to I think that in valve disease, surgeons are extremely important. And in fact, in the field of valvular disease, we as cardiologists, we are going after them. And they are the ones who are really doing the job. And I think that sometimes in the cardiology setting, we need good surgeons, but if I were a surgeon, I would also say I need a good cardiologist. And this is something that has to be really reinforced.
Okay, so thank you very much. I think it was quite exciting. We were privileged to have these really protagonists of these three guidelines, and thank you everyone for your attention and for your participation, and of course the three speakers for the brilliant presentation and sticking to the time.